originated the structurally rooted biopsychosocial analytic framework Weathering, which posits that the health of marginalized communities becomes increasingly vulnerable to chronic disease, adverse pregnancy outcomes, and death in young through middle adulthood as a consequence of active, high-effort coping with racialized stressors, both objective and subjective. She studies the collective strategies communities employ to mitigate, resist, or undo these harms, and the trade-offs these strategies reflect and the perturbations public policies sometimes cause in these autonomous protections. Dr. Geronimus.
Hi. Are you there? Am I here? I should say, am I here?
Yes, we can hear you.
Okay. Thank you very much, Jane. It's a pleasure to be here. And I will be talking about weathering in somewhat broad terms, and then also how it relates to the pandemic today. So after failing the literacy test in her first attempt to register to vote, Fannie Lou Hamer, the Mississippi 1960 civil rights activist who died at age 59, stated to the registrar of voters, "You'll see me every 30 days till I pass the test." I heard her say that, that's how old I am, and hearing that as a young girl, I was appalled to learn for the first time of racism and voter suppression. But I was also deeply affected by Mrs. Hamer's declaration of perseverance. Reflecting in later years on her persistence against the aggressive campaign to suppress the Black vote in the Jim Crow South, Mrs. Hamer observed, "I guess if I'd had any sense, I'd have been a little scared. But what was the point of being scared? The only thing they could do was kill me, and it kind of seemed like they'd been trying to do that a little bit at a time since I could remember." Mrs. Hamer's words read as a metaphor, but they are also quite literal. Marginalized Americans are disproportionately more likely to suffer from chronic and infectious diseases and to die at much younger ages than their middle and upper class white counterparts. The disproportionate injury to Black, Latinx, Pacific Islander, and Native American populations caused by the COVID-19 pandemic is a current, dramatic, and highly publicized instance. Next slide, please. And here you just see that this is really just since December. So these are the rates of death for different demographic groups in our, or so I would call them social identity groups in our country. And you see that they're not only unequal, but the inequality is rising, and that the indigenous people are actually having the worst outcomes, and second to them are Black. The country is waking up to what Black Americans have known for centuries and what public health statistics have shown for decades: systemic injustice, not just in the form of racist police protocols, for example, but in the form of everyday life, take a physical, too often deadly toll on Black, brown, poor, and other culturally oppressed and politically marginalized communities. Mainstream social epidemiology now acknowledges the contributions of interpersonal racism, racialized stress, and implicit bias to population health and equity. Next slide, please. It also increasingly recognizes that current and historical racist policies place barriers in the way of healthy lifestyles by institutionalizing food deserts, housing decay, and austerity urbanism. Essential as these developments in the field are, and they are, they only skim the surface of how insidiously structural racism establishes and reproduces population health inequity. I coined the term weathering to describe the effects of sustained cultural oppression upon the body. Weathering expands on the typical social determinants of health approach to understand the contextually fluctuating, historically structured, and socially situated material, environmental, and I want to highlight biopsychosocial stressors that wear out health of oppressed populations and shape their high effort coping strategies, such as Fannie Lou Hamer's needing to go over and over and over to try and register to vote. I call this process weathering because the word is a contronym. Next slide, please. Weathering, I'm sorry, previous slide. Weathering is a contronym. It's a sign of deterioration and erosion in response to outside forces, as in the rock was weathering from the storm. And that is a more intuitive understanding that many people are able to process. But I think just as important in weathering people is the other meaning of weathering, which is as a sign of strength and endurance, as in the family is weathering the recession. For health and aging, it can be both. To be weathered is to be subjected to the structural challenges and existential insults that our society creates for those we marginalize, and also to remain hopeful, tenacious, and motivated to overcome these barriers to a healthy and equal life. When oppressed groups use Mrs. Hamer's words, as they do to this day, and speak of being sick and tired of being sick and tired, which was her term or her phrase, they are right physiologically and also existentially. So what is weathering from a biological mechanistic perspective? Weathering is what happens to human bodies down to the cellular level when they grow, develop, and age in a systemically racist, classist, sexist, religiously intolerant, gender binary, or xenophobic society. Weathering leaves members of oppressed populations more likely to die or suffer chronic disease and disability long before they are chronologically old. No matter their work ethic or how decently they live, even in part because of how hard they work in the face of system-wide barriers, members of culturally sidelined groups weather. Next slide, please. This is a sort of a conceptual model of weathering, and it emphasizes health as an emergent capacity. So your health emerges as you develop as a fetus, as you develop and grow as a child, as you live your lived experience day after day, year after year, decade after decade, as you're an adult. Your health develops over the lifespan in response to multiple nested and contextually fluctuating socioeconomic, psychosocial, and physical environmental stressors. Through weathering, members of marginalized populations age young in response to chronic physiological stressors. And this model you can find, if you can't see it too well, it's in a paper that's just out in the Milbank Quarterly, and it ties together how structural influences, historic and ongoing, affect life experience and become biologically embedded or increase stressors on the body and stress-mediated wear and tear across body systems and organs, and eventually lead to higher rates of cellular aging, biological aging more broadly, and early death or disability for some groups relative to others. So weathering stressors go well beyond the stresses one cognitively perceives or identifies as stress. This isn't about being crazy busy while you're upper middle class. This isn't necessarily that something stressed you out that you can identify. The stressors I'm talking about are of many kinds and are ubiquitous. And you don't have to be conscious that they're happening to you for them to be affecting your body. They can be objective and environmental, for example, being exposed to toxic environmental and ambient stressors like air or noise pollution, or living through a very cold winter with rodents but not heat in your apartment. They can be subjective, such as having sustained cognitive and emotional engagement with your landlord while trying to persuade him over months and months to fix your furnace. They can be massive, such as when your child is ripped away from you at the border as you cross to seek asylum, or you experience a militarized drug raid of your apartment while your kids and elderly grandmother hide in the corners of the room and the police refuse to realize they have the wrong address. Or if you are subjected to or simply hear about, as a study I did several years ago showed, a militarized ICE raid in a meatpacking plant that employs people who share your ethnic profile. They can be symbolically triggered, such as when you are exposed to the footage of Black individuals being killed by the police in the light of day for no justifiable reason in looping news clips shown over and over for days. They can encompass fears and anxieties, sustained, as I said, cognitive and emotional engagement with social injustice or material hardship, and vigilance to threat. Moreover, injustice and trauma can be relived or ruminated upon without a clear endpoint. That's part of what makes these stressors chronic. That's one dimension of the chronicity of them. They also can be part and parcel of the emotional and physical toll of activism. This is high effort coping and peaceful protest if these efforts fall on societal deaf ears or are met by violent counter protests or police brutality. The human body is adapted to withstand chronic multi-level, or it's not, I'm sorry, the human body is not adapted to withstand chronic multi-level environmental and psychosocial stressors as I've described. Instead, human bodies, as many of you probably are aware, are adapted for short bouts of fight or flight in the face of acute and rare life or death threats. So as you know, mechanistically, thank you. As you know, mechanistically, the physiological stress response increases breathing, heart rate, and blood pressure to circulate oxygenated blood towards large muscles quickly. The body activates the sympathetic nervous system to release the stress hormones norepinephrine and epinephrine, and triggers the hypothalamic pituitary adrenal axis to release the stress hormone cortisol. SNS activation causes the veins in our body to constrict, increasing blood pressure as the heart pumps with greater force. The released stress hormones also activate a breakdown of triglycerides in fat cells, protein in non-exercising muscles, and glycogen in other body cells. Meanwhile, cortisol also disrupts any insulin in the bloodstream from storing these energy resources back into their storage cells. And as a result, the bloodstream is flooded with glucose, fatty acids, and amino acids that are used to fuel the muscles in the body and respond to the stressor. After surviving an acute attack, this cascade recedes and your body returns to homeostasis. And one can think of it as a process that should be over one way or another. You know, either you're dead or the animal that attacked you is dead, or you've managed to flee within 3 minutes. Adapted for. But when the physiological stress process is not completely deactivated, the body experiences overexposure to stress hormones. In these cases, one's state of physiological stress arousal will not recede quickly, and psychologically adverse experience can remain physiologically stressful far beyond their actual occurrence in humans. The toothpaste cannot be put back in the bottle. In other words, the same physiological responses that protect us against immediate and finite life or death threats can be damaging if they are sustained, whether through repeated acute or chronic adverse experiences, exposures, thoughts, protracted vigilance, and long periods of overexposure to physiological stressors result in allostatic load or stress-mediated wear and tear throughout the body, which is associated with multi-system health vulnerability and dysregulation, damaged tissues and organs, and accelerated cellular aging. And if you go to the next slide, I just want you to see these patterns by age, race, and gender. These are your probability of having a high, so unhealthy allostatic load by race and sex. And what I want to point your attention to is that the two curves on top are Black women and Black men, and the two on bottom are white women and men. And so there is a disparity at all ages, but it increases exponentially, the racial disparity with age, and this is over the young adult through middle ages. And also that the people who have actually the highest allostatic load are Black women. It's both higher to begin with, and it rises more rapidly. But Black men are not far behind, and they're both quite worse than white men and women. So chronic exposure to objective and subjective stressors over years and decades owing to structural racism means that stress hormones chronically flood the body over years and decades. Chronic activation of physiological stress processes has both rapid and enduring consequences for physical health and longevity. A massive acute stress exposure on a weathered body can result in cardiovascular events, or if you're pregnant, poor birth outcomes. Over time, chronic exposure to everyday challenges and threats has detrimental effects on cellular systems, including pathogenic gene expression that can result in cancers and acceleration of the cellular aging process. Prolonged exposure to stressors weakens the cardiovascular system, the immune system, the neuroendocrine system, and the metabolic system. It damages vital tissues and organs. It increases abdominal obesity, the risk of early onset of diseases of aging, poor immune response to infections, autoimmune disorders, and cancers. And again, this is independent of lifestyle factors, and when it interacts with unhealthy lifestyle factors, it's particularly bad. Among its physical health effects, chronic exposure to physiological stress processes also impact your brain. It can affect brain structure and leave people more susceptible to anxiety and mood disorders, including depression. Prolonged toxic stress exposure can result in the propensity towards anxiety, vigilance, and a low threshold for physiological stress arousal to become embedded. So that's a sort of pernicious, negative, recursive process where you actually become, your physiological stress response is triggered much more easily. Again, this is something adaptive if you're in a high-risk environment, but it causes greater weathering at the same time if it's chronic. And this can result in enduring changes in brain architecture and hair trigger stress arousal, setting off negative recursive processes that are weathering to mind and body. So the majority of empirical literature has documented patterns of weathering among US Blacks. This graph I have up of allostatic load shows a typical weathering pattern, which is that pattern of at younger ages, the Black-white differences are not huge, though they exist, but then they increase very quickly over the reproductive and working ages. The majority of them, there's also growing literature illustrating that increased risks of poor health outcomes related to weathering are observed in Latinx populations, Muslim populations in the United States, the poor across race, ethnicity, and people who have been subjected to adverse childhood experiences or severe trauma, whatever their social identity or socioeconomic background. Through weathering, members of marginalized populations age young, no matter how well they follow the American Creed or the latest dispatches from the front of healthy behavior science, sometimes because they do. For example, if one must work night shifts to make ends meet, that employment provides necessary income, a plus. Yet it also exposes the night shift worker to several sources of physiological stress that may contribute to weathering. For example, night shift work disrupts circadian rhythms, which is identified as a probable carcinogen associated with cancers of the breast, prostate, colon, and rectum. Night shift work may also expose workers to toxins in the workplace because the nature of those jobs, or at the bus stop, anxieties about whether one's children are okay home alone at night, and fear or protracted vigilance as night shift workers navigate their way home on unreliable and deserted public transportation, feeling compelled to remain hypervigilant to possible threats, no matter their state of exhaustion or any indignities they may have suffered recently on which they may be ruminating. Next slide, please. Erica Garner died at age 27 in the last days of 2017. Her own difficulty breathing due to severe asthma precipitated a major heart attack that killed her 4 months after the birth of her first child, classifying hers as a maternal death. According to her doctors, the pregnancy had stressed Garner's already enlarged heart. Conventional wisdom has us simply classifying her enlarged heart as a pre-existing condition. But we should ask how she had an enlarged heart at such a young age. Vague attributions to family history or presumed unhealthy behavior allow many of us to sort of brush off that question or feel that we've answered it. But the mechanisms of weathering also provide a plausible scenario. Erica Garner was a Black woman of modest means raised in a segregated, underinvested, and physically decaying urban area who became a tireless advocate for racial injustice after her father, Eric Garner, became a victim of homicide at the hands of a New York City police officer who placed him in an unauthorized chokehold for selling untaxed cigarettes. Her father's dying words, as you know, "I can't breathe," became a rallying cry for the Black Lives Matter movement. And Erica Garner, although initially apprehensive, became a major force in the movement for police accountability. Next slide, please. Given her lifelong hardships and stressors intensified by her father's brutal and very public and unjust death, and the sober and unrelenting activities she then assumed as a leader in the Black Lives Matter movement, it's easy to posit a cascade of weathering processes that enlarged her heart by her mid-20s and contributed to her death. In the weeks before her death, Erica Garner described the stress, exhaustion, and frustration that was exacted by her activism as a leader in the Black Lives Matter movement for police accountability. She said, "I'm struggling right now with the stress and everything. This thing, it beats you down. The system beats you down to where you can't win." Or as her sister, Emerald Snipes Garner, described it a week after Erica's death, it was like a Jenga. Next slide, please. They were taking out pieces, ripping her apart. One way to think about weathering is as a life or death game of Jenga. The scaffolding appears strong as blocks are eliminated. It remains upright as the first pieces are removed. One by one, people attempt to engage in high effort coping and to stand strong in the face of adversity. To all appearances, it continues to stand strong until the removal of that last fateful block exposes the many weaknesses of the interior and the tower collapses. In 2020, COVID-19 turned out to be that last fateful block for more than 200,000 people of color. Systematically racist labor market segmentation unduly exposes people of color to the virus, and many people have come to understand it if they didn't before. They're disproportionately deemed essential workers, more likely to be detained or incarcerated, and more likely to live and work in overcrowded and unhealthy conditions with others who are also excessively vulnerable and exposed with little chance for social distancing. Given the role of our racist history in labor market segmentation, obviously there's no reason to be totally surprised that bus drivers or nursing assistants or orderlies or cleaning crews who handle the bodily fluids, human waste, and dead bodies of COVID victims in the big city are disproportionately Black or brown, or that the line workers in meat packing plants in the rural South and Midwest, often Latinx, have higher infection rates. Meat packers work in overcrowded conditions amidst forced refrigerated air systems that can blow droplets containing COVID-19 into their eyes, mouths, and noses like the big bad wolf. Indigenous Americans too often live without running water in overcrowded and unsanitary conditions, as do seasonal farm workers, disproportionately Latinx, who work side by side in the fields without running water or toilet facilities or PPE, and cannot social distance or adhere to other public health recommendations. People of color are disproportionately and inequitably confined in jails, prisons, or immigration detention centers as a function of their design and operation. All of these settings are flashpoints for the rapid spread of infectious diseases such as COVID-19. So it's arithmetically straightforward that so-called essential workers are disproportionately infected by COVID-19 because they are much more likely to be exposed to the virus. But while necessary, the greater likelihood of exposure and thus infection does not on its own adequately explain why working class and people of color with COVID-19, especially young through middle-aged adults, are so much more likely to die from COVID-19. Overall, more than 90% of younger adults who get sick from COVID-19 have mild to moderate symptoms if they have symptoms at all and recover at home. However, among adults ages 25 to 44 years old, Black, Latinx, and Native people not only account for a disproportionate number of COVID-19 deaths as they do at all ages, but they account for the vast majority of deaths in that age group. The greatest age-specific disparities are actually at younger ages. Under age 60, Blacks and Latinx are about 6 times more likely to die than whites with COVID-19. In the oldest age group, where death rates for everyone are highest, the disparities are only about 1.5 to 1. While an equitable access to medical care does play some role in the higher rates of COVID-19 deaths that are being documented in Black, Brown, and Native communities, and as we've developed tests and now vaccines and treatments, inequities in access to those will enlarge the contribution to the inequity that healthcare per se makes. The role of healthcare access was really not the explanation for the initial disparity early in the pandemic, when we had no treatments or cures or vaccines against the virus. So why even then were young and middle-aged adults in marginalized groups more likely to suffer severe COVID-19 and die? Assessments that individuals 65 and older are at a highest risk of dying from COVID-19 may be true for the advantaged, yet ignores the basic fact of weathering, that members of populations subject to weathering are biologically older than their chronological age. This historically and structurally rooted fact contributes to most racialized health inequities, as I said, from infectious and chronic diseases to maternal and infant mortality to cancers. It is well accepted that individuals with underlying diseases that weathering mechanisms can lead to, such as diabetes, obesity, heart disease, and respiratory disease, and individuals who are of older age are at increased risk of having severe cases of COVID-19 requiring hospitalizations and dying of the infection. These conditions and diseases are most often construed as, quote, pre-existing medical conditions, end quote. But through a weathering lens, this construction is problematic and allows many high-risk cases to slip through the cracks or to be put too low in the queue for vaccines or be taken seriously enough to be admitted to hospitals. In other words, weathering implies that even if the stress-mediated biological processes have not yet resulted in a diagnosable disease, or if a person has not yet achieved the chronological age of 65, they are likely to experience early onset of elevated preclinical values on laboratory indices of chronic diseases, including in their blood pressure, blood sugar, weight, and amount of pro-inflammatory cytokines circulating in their blood. The construct of pre-existing condition leads us to miss large numbers of younger and apparently healthy people who in reality are at great risk of dying from COVID-19 should they contract it. Bodies, especially chronologically younger bodies, can be subject to the breakdown and vulnerability of weathering short of having a diagnosable disease, and can be closer to losing that last fateful block than others, even though they are appearing to stand strong. This disproportionate death toll of COVID-19 pandemic on the poor and people of color lays bare the fact that weathered bodies are more vulnerable to the worst ravages of infectious disease outbreaks. Once infected, weathering has left them with dysregulated or exhausted immune systems that undercut their ability to mount proper immune responses or lead them to have cytokine storms and injure organs and lead them to fail, which is one of a major route for dying from COVID-19. That weathered people may already suffer damaged tissues and organs, leaves them more vulnerable to the organ failure should they have a cytokine storm. Further, those who may survive a cytokine storm are at great increased risk of harboring long-term damage to their respiratory and cardiovascular systems, implying they may be dramatically further weathered by the autoimmune sequelae of this acute infectious assault. Before COVID-19, and for those who evade or survive it, members of populations that are marginalized, whether by race, ethnicity, poverty, religious affiliation, sexual orientation, gender identity, immigrant status, or identified at the intersection of any of these, will succumb to the loss of their last fateful Jenga block sooner than if society had assured them equal opportunity to die from natural causes at the close of a long life. It's long past time to do something about it. Everyday towers are collapsing before our eyes. Next slide, please. To summarize, whether mounting a physiological stress response is protective or damaging depends on whether the stressors you face are acute or chronic, whether you can achieve a satisfying outcome and in short order, and whether you have sufficient health, support, resources, and power to do so. To the extent that you are marginalized culturally, residentially, economically, or politically, you are more likely to face unremitting stressors, i.e. to be subject to the structural violence and the weathering it induces. To end weathering and not only ameliorate some of its physical health manifestations, we need to find ways to stop the structural violence. Next slide. Thank you very much, and I'm happy to take questions.
Thank you so much, Dr. Geronimus, for that such insightful talk. I think as medical students, we're often taught about the that race is a risk factor for certain diseases, and we're not taught about the reasons why. And so I think your work on weathering is so critical to understanding the structural issues at play when we talk about race as a health risk factor. So thank you so much for elaborating more on your research. I will now open the floor for any questions. You can unmute or you can drop them in the chat. We also have a few that were submitted beforehand. And I think one that is particularly relevant for us would be, Dr. Geronimus, what can healthcare providers do to mitigate the harmful effects of weathering? Oh, you're muted, sorry. Oh, she can't unmute.
Okay, thank you. I'm sorry, would you repeat the question?
Sure. So for healthcare providers, what can we do to mitigate the harmful effects of weathering?
I think, first of all, just, you can do things as healthcare providers and also obviously as citizens and voters. But as healthcare providers per se, I think being aware of weathering is pretty important to understand that 20 does not equal 20 and 30 does not equal 30. And ages that we think of as very low risk ages for major health problems, whether they be COVID-19 or they be, say, infant and maternal mortality or other adverse birth outcomes, or heart disease or hypertension, that we realize that people coming from certain social identity groups may not be as healthy. We have to kind of move beyond just a developmental understanding of the risks of poor health outcomes with age. We have to stop thinking that sort of the 20s, 30s, and 40s are sort of prime health for everybody, because they're not, or are low risk ages. We need to think about, as I said, these processes happen whether or not you engage in what we think of as unhealthy lifestyles. And they can also even physiologically increase your chance of engaging in a healthy unhealthy lifestyle. For instance, certain of the physiological hormonal reactions can lead you to crave high comfort foods, high fat and sugar foods, so-called comfort foods, or they can lead you to crave drugs or to smoke. And when you add that to some of the other more mainstream ideas about social determinants of health, that you have no grocery stores to get healthy food, but on every corner there's a liquor store or a place you can get cigarettes, or you can get very unhealthy foods. You have this sort of set of processes that together contribute to weathering. And so I think if healthcare providers understand that just telling people not to smoke or the kinds of things you think you're doing to be preventive is a very kind of tip of an iceberg that's so much more complicated and has such strong health impacts. I think that might be, something to do. To the extent you have policy, you're part of a task force figuring out, vaccine eligibility. I think taking weathering into account would lead to different, ideas of who should be prioritized. And so I think there's a variety of things, but the main thing is changing your mindset. So if you see a woman come married in, say, her late 20s or 30s, you don't just say, oh, she's going to be fine. This is an uncomplicated, easy pregnancy. In fact, you stay open to the possibility she may be weathered, which will increase hers and her baby's risk. And so then if she comes to you and says things like, something's not right, maybe you don't say, oh, mothers are all worried. You say, uh-oh, this might be something and we should double check. So that would be another example of a way you could apply weathering to your actual everyday practice.
That makes a lot of sense. There is a question in the chat. So is there evidence that this phenomenon of weathering is occurring at higher rates in certain parts of the country?
Yes, is a short. One of the things about weathering and why it's so different from ideas that certain racial groups, might have some genetic predisposition, is that we see variation in weathering, whether it's in different geographic areas, which as you're talking about, or whether it's different eras. So for instance, high allostatic load scores were much higher among Black women in the 1990s than they had been in the 80s, or than they were again in the 2000s. So there are, because this is all mediated through what's happening in your lived experience, if life becomes harder for whatever reason, because of where you live, because of how little money you have, because of what the current political climate is or policy environment is, that will, around the margins, it doesn't mean you don't weather at all. If you're a culturally oppressed group, you always weather to some extent. I don't mean each individual, to distribution, but that there will be times, part-times in history and places where weathering will be worse or a little less bad. And the last thing I want to say about the geographic areas is that we've done work looking at telomere length as an indicator of weathering. And we find that, for example, we did a study in Detroit. We found that while all the poor residents of Detroit were their telomeres were shortening more rapidly than you would expect for their age, for their chronological age, the people who weathered the most were the poor, the very low income white residents of Detroit. And that Black residents were weathering pretty badly, but not as badly as the whites. And Mexican residents of Detroit who were poor actually weathered less than Mexican residents who had more resources or more education. And I want to highlight that for a minute, because we're so used to thinking that what causes this ill health or stress is, low income or lack of education. We sometimes forget to take into account some of those more biopsychosocial things. And what we've come to interpret those results, and other studies support this, is that because of a shared history of residential segregation and oppression, that of social coping mechanisms, kin networks, social support mechanisms that the whites don't have in Detroit, who are much more scattered and smaller number, and don't have a long history as whites of having, kin networks and coping mechanisms that work through networks of support. And that for the Mexicans, it's actually the poor ones have incredibly dense networks of support and ethnic enclaves. And those who go on to higher education or more middle-class jobs are more likely, sometimes for the first time, if they're from immigrant families, exposed to the racism against Latinx that we have in this country, and without real support systems to help with that. So I wanted to highlight that because nothing about this is simple or linear. You really have to think about what is the lived experience of whatever group. Black Detroiters don't have access to healthy food. They have poor access to health care. They have lousy schools that are also unhealthy physically. They grow mold. I mean, the Detroit public schools are horrendous in that regard. So those you think would all weather them more, and I'm sure that does contribute to their foundational weathering. But at the same time, they have social supports and coping mechanisms that are kind of autonomous ones that maybe help buffer. You can even think about that in terms of a metaphor with the COVID epidemic. If you wear your mask, you don't, and social distance, you don't absolutely, save yourself from getting COVID, but you do mitigate it, the chances. And so in some ways, I think almost ironically, those populations that have had long-term experience with historical oppression have figured out what some of those masks and social distancing analogous behaviors are, or social behaviors, while people who are poor for the first time or racistly oppressed for the first time may not have those coping mechanisms.
Thank you so much. Another question from the chat. So one of our attendees recently saw a tweet that said that in some locations in the United States, the life expectancy of African Americans is as low as 59. So if vaccine campaigns begin with vaccinating those in the 75 plus or 65 plus age groups, then the healthcare system is perpetuating medical inequalities like you were talking about. How can we change this practice in the future, or is there anything we can do now to mitigate that?
The vaccines per se, or the deaths at 59?
Either, both.
Easier to do the vaccines. Yes, one of our early studies that was published in the New England Journal of Medicine in the 1990s, we showed those kind of differences in life expectancy, even within the same, city. And nobody really picked up on that in the 1990s because we were so in a narrative as a culture of that, urban people are predators or, self-destructive or in a tangle of pathology, all those really hard, or should be, they're all criminals. I mean, it was a horrendously racist narrative that pervaded the country. And so when we published, and in a high profile medical journal, that life expectancies, for people in Harlem were so much lower than, say, people in Queens, New York. So not necessarily the most affluent areas. And that the primary cause of that didn't surprise people because they thought everybody was, killing each other or having drug overdoses. But what we showed the main causes of those early deaths were chronic diseases like cardiovascular disease and cancers, but people weren't listening. Now people are finally listening, and I think there are more studies that have sort of, in one way or another, kind of come to replicated ours, this idea of that in different parts of the country, even in the same city. I mean, some of those studies are just like county level, and that masks how bad it is for some people within those counties. So that's like the upper bound estimate for them of what their life expectancy is. So depending, you want to look at what level of geography that 59 is. And if it's a county, that means that's higher than it probably is for certain really oppressed populations in that county. The other thing I wanted to say about that is that it's not just that they have lower life expectancy, they also have lower active life expectancy. So they may have a life expectancy of 59, but they may become disabled, functionally disabled, in ways that interfere with their ability to work, or in the worst cases, even personal care or mobility, even younger than that. Or if they survive beyond 59, they have escaped that bad life expectancy statistic, but they may, because of weathering, have pernicious diseases or functionally limiting disability. So I don't mean to be the bearer of doom and gloom, although in some ways I do. But all these, most of those kind of statistics are telling you the best case, or just a superficial part, or one, maybe I shouldn't say best case, but one piece of what the whole problem is. But in any case, I think the vaccine thing is really out of hand currently, in not recognizing, for both reasons, both because of the much greater exposure to COVID-19 of people from these communities, but also because it's much more likely to become severe or even kill them. I think we really have to, anyone who has a voice in discussing vaccine priorities should be pushing for this. And anyone who's more privileged, shouldn't jump, as much as you might want to get a vaccine, maybe you shouldn't, if you have some opportunity to jump the line, don't.
That makes a lot of sense. Another question in the chat was, the idea of resilience is something that is often praised in society today. But do you think by framing adversity in a positive light in certain instances does a disservice to or distracts from the effects of weathering stressors day in and day out?
Yes, I think resilience is used too often, inaccurately, and with almost a magical thinking about the positive good it will do. What I'm calling high effort coping, you could also think of as resilience. These populations are fighting adversity every day and on multiple levels. It's not that they don't have resilience, but resilience is this sort of double-edged sword. And especially if, despite your fighting tenaciously and even hopefully, you can't, you're just batting your head against a wall. That's why I said part of what matters to weathering is not only being faced with the stressor, but actively trying to address it and not having the power or the resources to do so. So it becomes prolonged, active, effortful coping. So I think we think of resilience as a country or a profession, mostly in individual terms, and it's something maybe we could help teach certain people to have, or that we should teach people to have, and that will overcome their oppression or the discrimination against them of various kinds. But I think, as with everything else, it's so much more complex. We should first of all be more humble and realize people already have resilience. And they may have a better idea of what they need to do to be resilient to the particular stressors their community faces, but that being resilient also ages them. And so, for example, there have been studies that show that, for example, there's been a series in rural Georgia that looked at very low income Black children over time, and it assessed their psychosocial resistance and resilience and their ability to have what they call planful self-control, which in some ways is like high executive function and grit and all the things we think we should teach our children and want them to have and will only be good for them. But what they found is as they followed them over time, it was true that those who had those higher levels of grit or planful self-control or resilience were more likely to go to college. And this is an area where almost no one goes to college. They did do things that would help their socioeconomic mobility. They also found in their early 20s that they had experienced at the cellular level higher epigenetic aging. They were epigenetically older than their peers in Georgia in their same schools, in the same study, who had not pushed ahead to do well. And in some ways, this shouldn't be a huge surprise because for the history of thinking about things like cardiovascular disease, for example, we've thought of, even in non-oppressed populations, that individuals who have a type A personality, which really is sort of an internal locus of control and et cetera, often are more likely to get heart disease. I mean, the joke we used to tell when I was young was, if you had a type A personality, was, well, you're more likely to get a heart attack, but you're less likely to die from one because you'll get yourself to the hospital. So in some ways, some of these issues about resilience, should not be a surprise. And we've really sugar-coated resilience as a magic bullet of some kind without either respecting the resilience oppressed populations already have, or understanding that it takes a physiological toll when you're using that resilience against a very oppressive situation.
Thank you so much.
Mm-hmm.
Another question in the chat: is there evidence of other countries or even other states that provide better access to insurance or medical care access that would have been able to mitigate the weathering and improve outcomes?
Not directly. I don't know that people have literally studied weathering in other countries. But what is true is there's two ways to think about how you could mitigate weathering. There's at least keeping it from killing you. So you haven't stopped the weathering, but you've gotten access to health services that are like tertiary or even secondary or tertiary prevention. And so like that type A person who gets to the hospital in time, they're actually more likely to get the heart attack, but less likely to die. So certainly at that level, having good access to healthcare and equitable access at least can help stem the worst outcomes or the fatal outcome of weathering at a young age. In terms of preventing it from the beginning, I don't think there's a lot of data on that, but to the extent that we don't see as early onset of chronic disease in other countries that do have better access to healthcare. And if we think of better access to healthcare as not literally just about the healthcare, but a sense of a broader social safety net, a sense of collectiveness, that we care for each other, social security, that all people belong. You don't have to like be means tested or prove you belong. Those are weathering stressors too. And so I think you can think of the healthcare access as definitely mitigating deaths from weathering, but also possibly being part of a culture that makes the worst weathering or the biopsychosocial aspects of weathering less likely to occur.
Thank you. Another question in the chat asks, so the ACE scores or adverse childhood experience scores are often used to indicate a predisposition to chronic illness later on in life as well. Do you think that an elevated ACE score has a direct enough correlation that links to weathering that would sort of indicate a patient should have more frequent or extensive health screenings in the hopes of preventing further degradation of health and advanced metabolic aging.
I think people with high ACE scores, that would be one very crude way to kind of identify some people who may be more likely to be weathering. The ACE itself, the actual events, are things that are actually very common in populations subject to weathering. We have this idea that ACE scores are rare traumas, or just kids with horrible parents, or just the most poor people or most deprived. And we use words like trauma to talk about them, which gives a sense of how it sounds extreme. Part of what I'm trying to say about weathering is what systemic racism has done is it's made that the things we talk about as trauma in a say middle-class child be everyday experience for people of all ages in certain social locations that are identified by race and socially patterned in that way. And so in that sense, as a crude measure, since we can do ACE, it could give some insight, but there are probably a lot of people in weathered populations who are weathered with or without the right number of exact ACE scores. And and in many ways, the ACE test is culturally biased and doesn't really encompass enough of the stressors. So it's sort of like resilience. It's kind of like, yeah, it's a crude measure, and maybe that's better than nothing. But we framed it in such a way for it to be rare, extreme, and be through these very major life events, like the death of a parent, or extreme hunger, or abuse from a parent, that I think we're missing. It's sort of like what I said about pre-existing medical conditions. The ACE will capture some of these issues, but will miss many more than it captures.
So it's better than nothing, but we should find something else that's more wide encompassing.
And what I'm also saying is a lot of weathering happens in the 20s, 30s, and 40s. And so whatever happened to you as a child, I think we have a paradigm that says you're very vulnerable as a child and you're very vulnerable again when you're elderly, but in between, you're robust and fine. And the reality is weathering just happens throughout your life. And in some ways, it both accumulates, increases, and may be actually more stressful given all the competing obligations people in their 20s, 30s, and 40s have in those decades. And a measure of childhood events isn't going to tell you about the current things that are weathering people.
That makes sense. Another question in the chat. So the homeless population could be, or I guess, would you consider the homeless population to be one of the most weathered groups? And
absolutely.
And then as we're talking about getting the vaccines out to populations who are the most weathered, who are the most in need, do you have any thoughts about what we should be doing to make sure that our homeless populations have access to the vaccine?
Well, first of all, maybe we want to, if there's any way we can help support getting the Johnson & Johnson vaccine going, which is just one dose, that would be helpful. But I think you have to have mobile vans. You have to have going into shelters, though a lot of shelters have shut down because of COVID and no social distancing. So I think that it's particularly hard to reach the homeless now. I don't have an answer to that, but yes, the homeless are as weathered. I mean, there are so many weathering stressors, objective ones, social isolation, physical assaults, not being able, if you have, say, diabetes, to be able to have your insulin either because you can't get it, or you're afraid if you have a syringe on you, you're going to end up getting raped for people who want those syringes if you're a woman. Yeah, that's a huge problem, and I wish I had just a simple answer, but I don't. But I don't see any answer that doesn't involve mobile vaccination.
That does make the most sense, bringing the vaccine to people. I've also heard of that option as being something to equalize the current vaccine distribution just in general, is bringing the vaccine to people's homes for people who can't travel or don't have access to the internet. So that does make sense. Another question in the chat. So intrauterine stress prior to birth could be part of weathering. Would you include that period of life of intrauterine as a part of weathering?
First of all, there's a lot of evidence that chronic stress development. I made an allusion in my talk to a study we did on the post-fill raid, which was an ice raid on a meat packing plant in Iowa. That was very militarized, and I won't go into all the details because they're gruesome. But pregnant women who were Latinx throughout the state of Iowa, so they didn't have to be even in post-fill, they didn't have to be in the raid, had increased risk of preterm deliveries and low birth weight babies. So just the stress of knowing that could happen to other people who are of your ethnic group affected their pregnancies. But we also know that cortisol breaches the placental barrier. We know that when you go into the fight or flight response, that one of the things it does is it sends, while it's busy sending all this blood and oxygen to large muscles, it's taking them away from other parts of your body that aren't necessary to fight or flee, or might even be a drag on the system. And a developing fetus is one of those. If you have, we didn't talk much about environmental exposures, but one of the things that happens, let's say if you've grown up in a community with a lot of environmental lead, which is the only way you get, lead has no known good thing, no known source that isn't environmental, and no good thing it does to the body. So if when you're pregnant, you have built up a store of lead in your bones and bloodstream, and then part of what pregnancy does leaches some of those out of your bones, so you have higher circulating blood lead that crosses the placental barrier and gets absorbed like a sponge by the developing fetus. So in fact, the early, we know about early childhood exposure to lead when it's a kid eating, drinking water in Flint, or eating soil where there's a lot of lead, or living next to, a smelter factory. But it can begin through their mother's exposure to lead. It can begin in utero.
Thank you so much. At this time, we will end this talk. Oh, okay. There is one more question.
Okay.
As you briefly touched on in your talk, racialized differences in health outcomes are often attributed to genetic differences or ancestries without reference to socioeconomic circumstances. Is an understanding of the historical and current social, political, and economic factors that affect social groups and the way those contribute to things like weathering are of more explanatory value to clinicians and patients and researchers rather than genetics?
Absolutely. I mean, on an individual level, genetics can matter. And we're certainly moving in the medical field towards precision medicine and, looking at your individual profile. But in the bigger picture, and certainly in the weathering picture, genetics is not the problem. I mean, there might be gene environment interactions that affect where you are in the distribution of your group on certain things, but those are individual. That's not because you're part of the group. And this idea that these racial differences, for example, are genetic or ancestral is part of the problem that we have in misunderstanding what causes these huge inequities and therefore getting the solutions wrong. Yes, I firmly believe and have studied and could probably give you a whole nother talk on why these factors are far more important than genetic factors.
Thank you so much for your talk and for spending this morning with us, Dr. Geronimus.
Well, thank you very much.
So now before we go to our 10-minute break, I would like to introduce Tram. She is our logistics chair for the British to Access Conference, and she will be explaining how to self-select into breakout.
Good morning, everyone. Thank you for joining us today.